Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is titled, The Doctor Will See You Now, Getting the Most from Your Surgical Consultation. The presenting provider is Trinity Health IHA Medical Group Neurosurgeon Jay Nathan. Dr. Nathan sees patients at our practice in Livonia on the campus of Trinity Health Livonia Hospital. Welcome, Dr. Nathan.
Thanks so much. And thank you everyone for joining on this Wednesday evening. Really appreciate your time and attention. I hope to make this interactive towards the end. As mentioned, definitely encourage questions. Looking at some of the topics on recent Wednesday Wellness talks, some of my colleagues have given great presentations already, covering a lot in the area of neurosurgery in low back pain and neck pain. So I wanted to touch on that to some extent and talk about neurosurgery topics, but take a step back and pull back the curtain a little bit on kind of the process of getting a consultation with a surgeon. A lot of what we'll talk about this evening is broadly applicable. So even if you see your primary doctor or a specialist in another area, just trying to provide a toolkit for how to approach that, to reduce some anxiety, to kind of help make sure that you get the most out of that consultation, and that we can do our job of really caring for you and addressing your goals and concerns. So who am I? Just a kind of few words to introduce myself. I'm a board certified neurosurgeon, did my medical school training at Stanford, and then came to Michigan to do residency at University of Michigan. I finished 5 years ago. I completed a spine fellowship at Stanford for 1 year, and that was basically additional subspecialty training focused on more complex spinal surgical conditions. Within neurosurgery, we treat brain and spine conditions. I also take call at Trinity Health Livonia Hospital. So for more urgent or emergent conditions, I'll see patients for brain and spine concerns. And then, as mentioned, my clinic is here on the hospital campus in Livonia to address more elective or kind of outpatient questions. So if you see your primary doctor and then get a referral, we have the clinic for that. Just a brief word on what the board certified means, because I think that term gets thrown around a lot, but folks don't necessarily know the full process, and it's a long training process. So after completing residency, at least the way it works in neurosurgery, is we then practice for a few years and actually collect information on patients that we treat and submit that information to our board, the American Board of Neurologic Surgery. And it's a pretty rigorous process. They actually review over 100 of our cases to make sure that we have good outcomes, we're operating for the right reasons, patients are doing well. And if all that looks good, you're invited to sit for an oral exam where you're kind of grilled on some of those cases and on general topics in neurosurgery. So that board certification process actually happens after you're done with training, but is designed to help make sure that neurosurgeons are practicing with a high level of quality. And quality of care, value of care is something that I'm particularly interested in making sure that we improve as a field. I've been able to work on that on a health policy level and kind of thinking about ways to augment or design policy to make sure that that supports good patient care, and also thinking about that at the practice level. So at the hospital level, thinking about how do we improve patient safety, how do we improve quality of care, on a system basis, how can we sort of do that on a regular basis so that you as the individual patient get the best care, whether it's an emergency or not. And my primary role as a neurosurgeon, with the word surgery right there in the title, is of course to perform surgery. But really my goal is to make sure that we're doing that for the right reasons, to help you, the patient, to make sure that we know what we're getting ourselves into with surgery. And so thinking about, is surgery possible to address the condition? Because as we'll touch on later in the talk, not all of our conditions, not all spine conditions can be treated well with surgery. So thinking about, is surgery actually even an option for you? And then is it the right option for you? Is it the advisable next step to do? Or thinking about timing of that in relation to what other treatments might be available. Some key points that I want to touch on for today, kind of, wanted to give you if you had to step away early or if you took nothing away from this talk. I think one really key point to touch on is, if possible, try to come to that appointment with your surgeon or with your specialist that you're meeting for the first time. Try to come prepared. And I think that's really important, that it's a meeting of the minds. It's not really my role just to tell you what to do. I need a lot of background information to kind of help inform that decision. We want to make that decision together. So it's really important to kind of come in thinking about what are your symptoms, what's been going on, what's concerning to you, when did that start, what makes it better, what makes it worse. Those types of considerations, just kind of as a broad outline. Tell a succinct story. If you need to, write down some notes to kind of help you remember the key points. Don't worry about minor details. We want to think about what's impacting you, not necessarily specific dates or specific people you might have seen before. Reflect on what's really important to you, what's driving your concern. Maybe there's something that you really love to do that you can't do anymore. That's the kind of information that we want to know, so we know how best to help you. Ask questions by all means. I mean, you're the patient. I definitely want you to be informed. I think most doctors would agree that an informed patient is going to have better outcomes. So make sure to think about questions ahead of time that you might have, write those down, and then take notes if possible during the meeting. If you can bring a friend or relative along, that's hugely important because they can jot down notes for you. It's hard to remember a lot of the information, and I get that. And so I also try to plan the pace of the visit to make sure that you have time to ask questions and to take notes, and then also provide you with notes after the meeting to capture some really large terms, difficult terminology, and important concepts. We'll talk about red flags that you want to look at that, maybe you're consulting with someone and you're not getting a good feeling, what to watch for and kind of choosing the right surgeon for you. Seeking second opinions, whether there's a red flag or not, even if everything went well, I would never be offended if you sought a second opinion from somebody else because it's good to get multiple eyes on a problem, especially if it's a big decision, especially something like spine surgery. That's a major decision and that can alter the rest of your life. So it's really important that folks are going in well informed and feel comfortable with the whole process. And remember that, just as with everything in life, nothing in surgery is guaranteed. There's tremendously impressive things we can do in medicine and in neurosurgery. The technology has come a long way, even over the last couple decades. But that doesn't mean that we can solve all problems or we can prevent all problems. We do our best. And it's important to know that risk is an element of life and it's an element of medicine. We try to manage that together and figure out what's the safest and most effective path forward. So an analogy, to kind of thinking about this visit that we all just had to deal with is taxes, so it's kind of fresh on the mind. So I thought I would use that as kind of a fun analogy. Imagine you're going to your tax preparer. You may have just done this over the last few weeks. And you go without really anything. You don't have your W-2, you don't have your 1099, maybe your property taxes if you're going to get a Michigan property tax credit. You hadn't even really thought about what records you had to bring. You just kind of showed up and figured, well, it's in a computer somewhere. They'll pull it up for me and do my return. And you want them to get the return done. Maybe it's April 10th and you're kind of on a tight timeline. That clearly isn't possible, right? There's no way that preparer can actually put together a correct return for you without the underlying information. And I think we all kind of understand that there's information that goes into it to generate the result. So it'd be really unusual for folks to show up without that information. Yet, as a physician, I see this essentially all the time, in the doctor's office, that folks are coming in, they want to know how to treat their condition, but we have very little to no information about that. Or maybe they haven't even thought about what information I would need to know. They haven't thought about why are they coming to see me? What do they hope to get out of the visit? If that happens, it's really tough for me to make an informed decision for you. I can make a decision, I can make a recommendation, but it's going to be really limited and probably not going to speak to what you need. So again, just kind of taking that mental framework, we want to think about how can we empower ourselves to kind of go in to get the most out of the visit. You're the patient. You should be in the driver's seat. You should not be a passenger in this process. And it's very easy in medicine for that to happen. There's a lot of physicians who are kind of guilty of that, of kind of dictating or sort of saying what needs to happen without necessarily getting input from the patient. And that's the fault of the physician as well, to not seek out that input. But you're not a passenger in the process. You're the whole kind of central reason why we're doing what we're doing. So making sure that you are in the driver's seat and you have ownership of what's happening and you can get the best outcome requires some thought and planning and effort so that we can make informed decisions together. So how can we come prepared to the visit? Well, think first of all, big picture. What do you hope to get out of the visit? What's the goal of the consultation? Sometimes if that's unclear to me, I'll ask that of patients, how can I help you? What is the goal that we're hoping to achieve from this visit? Because it's not always clear. If you reflect on that ahead of time, then that really solves a big challenge up front. Think about who referred you to see me, or recommended that you come to see me. Was it your primary doctor? Was it a neurologist? What perspective are they taking on it? Why did they make that referral? And if you don't know, ask them. If you're sitting with your primary doctor and they think, hey, you should go see neurosurgery, ask them why. What surgery are they thinking you might need, or what would be the reason for the consultation? Because that might elicit a chance or gives a chance for you to talk to your primary doctor about, is that actually the best referral for you right now? And if it is, great, and you sort of know what you're getting into. If not, then maybe you can direct that to something that is more appropriate. There's a big difference between being referred because of symptoms that you're experiencing, maybe they're concerned about a particular condition, versus a referral just for test results. So we'll talk about some examples of imaging studies and test results that you'll see on imaging studies, but really that doesn't drive a lot of what we do. In most cases, it's really about your symptoms. It's about what you're experiencing. So in thinking about that, kind of reflecting on being prepared for the visit, think about or write down a succinct story about those factors, about what symptoms you're having. Again, when did they start? In neurologic conditions, we really want to know what the pace of the symptoms were. It makes a big difference in our thought process of what it might be. Did it happen suddenly, or has it been going on gradually and eventually got to a point where it's intolerable, in the case of pain? That kind of helps us right away by knowing the time course, knowing the pace and the trend of symptoms. Maybe symptoms are getting better, which is great, and that changes kind of how we approach it. So that's the kind of information that we want as physicians. We want kind of encapsulated in that story. And that should come out very early in the visit of kind of, the physician or the advanced practice provider sitting down with you and trying to get that information. The quicker you can deliver that, and the easier the back and forth is, the better it is for you. It saves more time to then talk about treatment options, to answer questions, et cetera. Going on tangents, giving irrelevant info, sort of going off topic. A lot of folks want to come in and they want to talk. Maybe they have a lot on their mind that they're trying to offload and they want guidance on, and I get that. But no matter how much time we spend together in the office, it's always a finite amount of time. That's just the reality. And of course, everyone wants to have kind of unlimited time with the physician. But if that happened, if that were true, imagine how long you'd have to wait to go see a doctor. So there's a trade-off between how much time we can spend in the visit versus making sure we can get you in there in the first place and that we're not too delayed and we don't risk having a problem because, it took too long to see you. So we want to make sure to treat that time as being valuable on both ends and really focus the attention, focus the story on what matters to you and to your care. So an example of this would be a condition of spinal stenosis, which is super, super common. You may have heard of it. Generally, if you're in your middle ages, kind of 40s and above, if you were to do an MRI or CAT scan of your spine, you're probably going to find some spinal stenosis somewhere. Keep in mind that that's a description of a picture. All stenosis means is narrowing of some channel. So that might be in the very center of the spine where the spinal cord and the nerves are. It might be on the sides of the spine where the nerves are exiting the spine. You may have some narrowing there. That doesn't necessarily mean that that narrowing is causing a problem. It's kind of like on the highway, if you were to close a lane of traffic at 2 a.m., yeah, the highway's narrowed, but there aren't that many cars there. So those who are there are still going to drive at the same speed. If you do that in rush hour, you're going to get a different outcome. So we want to think about, does that stenosis actually matter? Is it producing symptoms? And so that's where I do see cases where sometimes folks get referred simply because a test was done and spinal stenosis was found and commented on. But that doesn't mean in of itself that you need surgery for it or that you're having symptoms from it. So I think it's important to remember in all of this that even if you're referred to see a surgeon, it doesn't mean you need surgery. Quite honestly, the vast majority of patients that I see don't need surgery, and maybe not even at that first consultation. Things could change in the future, but it's quite rare actually that we need to operate simply because of something like spinal stenosis. It's okay too to decide not to go through with that referral or to reschedule. So one example that I see time and time again is folks get better. Maybe they had intense nerve pain, they had like a sciatica type pain, and then it got better. And that's what happens about 90% of the time, is that it's going to get better. And sometimes it can get better within days to weeks. So if that's happened, if you've gotten better, and if that was the reason for being referred, you probably don't need to see the surgeon, if that's the case. And I get sometimes people want to still sit down and understand what's going on, and that's perfectly fine, but don't feel compelled to go through with it just because you had this problem and this appointment was made. If you need more time to get testing done, so MRI is a great example where an MRI gets ordered, but it can take a while to get it done. You're going to be better off having that test result. If it's an MRI of your spine and you're going to see somebody for a spine condition, I'm going to be more informed about what's going on if I have that test result. So rescheduling by a few days actually helps you rather than having a visit and then I'm not able to tell you much because we know that that test is coming. Or I've also seen it time and again where folks are referred to me, but they're adamant about the fact that they would not want surgery. That, again, I'm a surgeon, so while I can provide information and guidance, there's folks who can do that sometimes far better than I can and can actually start to provide some treatment. And so that's where, especially in cases of pain, where you're not interested in surgery, or that, even if someone were to recommend surgery, you wouldn't want to pursue it. We've got some great specialists within pain management that can help with medications or injections. And also physical medicine and rehabilitation are kind of the non-surgical physicians when it comes to the spine. You'll sometimes hear them referred to as PM&R or physiatry. So those are great specialists to go talk to kind of help manage pain that we don't need to do surgery for. No one's going to be upset, if you needed to cancel, reschedule. Usually it's actually helpful to other patients, helpful to the clinic to make sure that the visits are there for the folks who really need it and that urgent conditions don't get delayed. And that referral, in most cases, if you needed to reschedule it or postpone it, you can sort of keep that in your back pocket and use that later if the situation changes. In our clinic, for example, if it's urgent, we can get people in sometimes within 1 or 2 days. That's usually, our availability. So it's not like you're going to be pushed off, long, even if you had to reschedule a visit. Thinking again about kind of the purpose of the visit, what we're trying to achieve in discussion, we know how to do surgery. We know kind of the background, the sort of biologic basis of disease and how to treat it, but we don't know you. And so what really is important is kind of meshing those two things together. And what you're bringing when you come into the visit is the information about you. Don't assume that it's in the computer somewhere. It may not be there at all. If you had tests done, if you had records done at other institutions, it doesn't always come into our system. Even if it does, it can be very clunky and hard to find. We're trying to basically find a needle in a haystack, and that's not a great use of time compared to if you're able to sort of summarize for us or bring in the records to the visit that are relevant. It's kind of always about finding the sweet spot, finding the information that's really important and relevant, because it's not all important. Some of the information too, even if it's in the computer, may not be very reliable. You don't necessarily want me to act on it. For example, if you're seeing someone and you're kind of getting an initial impression before imaging testing is done, well, maybe that diagnosis no longer applies. Or maybe the treatment that you had before was for a slightly different condition, different situation, and doesn't apply right now. Or having folks who are not experts in that particular field. So in my case, in spine disease and spine surgery, while it's useful to get the impressions of other physicians, they're going to approach it with a very different angle and a very different background, and not necessarily have that specialty expertise. And so just having had that conversation with somebody else, maybe they asked you different types of questions, you've shared the information before, but the way that I ask the question or the things that I need to know is different. again, to help guide us in the right direction. I know it can be frustrating sometimes. It feels like you're repeating yourself, but the way that the question is asked and answered and kind of the specific information, what's going on kind of in the doctor's thought process, the gears that are kind of turning, is sorting through those different diagnoses and sorting through different treatment options so that after we get done with that conversation, we can give you our recommendation. An example of this kind of historical information that I see quite often is someone who's had spine surgery before, especially if it's done by a different surgeon, different institution. I don't necessarily have any of those records. And it's very vague sometimes in our chart, in our documentation. It might say you had lumbar spine surgery. Well, that can mean any one of 100 different operations. I don't necessarily know what was done. So if you have access to that information, if you already have it at home, even if it's not bringing the full reports, but just kind of jotting down your history, having that ready to go to say, they operated on L3 and L4. I had a disc herniation. My leg was hurting. Took out the disc and I felt better afterwards, right? So again, thinking about also why was that surgery done? Was it helpful for you? Or are the problems that you're having now, the symptoms you're having now, related still to that same underlying problem? Maybe you tried one surgery and it didn't work. That's a different thought process, a different approach than you got better, you're doing great, and now you have a totally new problem that's developed. Make sure at some point in the visit, maybe partway through or at the end, that you ask for and you get an actual diagnosis of what's going on. I think there's a trend that occurs in medicine. I see this in notes from doctors all the time. Folks jump to treating, and that's kind of in our nature. We want you to get better. But sometimes people skip over that thought process of, well, what actually are we treating? What's the diagnosis here? You got to get that right first. You have to know what it is that you're treating in order to make sure that you're prescribing the appropriate treatment. And maybe the physician's unsure of the diagnosis, and that's perfectly okay. That doesn't mean they're a bad doctor or that they don't have the adequate expertise. There is a lot of uncertainty in the practice of medicine and surgery. And it's actually the best physicians who recognize that and say, well, these are the things that it might be. There's a list of 3 or 4 things that I think it is. We're going to do this test to help us decide between 1 and 2. Or we're going to do a treatment that sort of covers all of those things so that we're trying to get you better. And then if we need to, we can do other testing to decipher it fully. So knowing what we're going after, what are the different possibilities that there might be, that everyone is sort of open to that uncertainty, that's super important. What are the goals of treatment, really for you? If you're having pain or other symptoms, how bothersome is it? It would be wonderful, of course, if we could eliminate the pain completely, if you could go back to 100%, but that may not happen. We may not get to perfection. So ultimately what we want to know is this something that, even if it lingered to some extent, is that manageable? Would you have an adequate quality of life? What's the level of function that you're hoping to achieve? Thinking in really concrete terms about this, are there specific things that you used to be able to do before the symptoms that you can't do, but you need to or want to get back to doing? The most concrete thing would be work. And it's really helpful for me to know your profession, to know what you have to do on a daily basis, because that also guides how we treat it and even thinking about the risk factors for the condition getting worse. There's hobbies, there's interests that are super important to people that, again, we want to try to support and facilitate as best we can. I'll also be honest with you sometimes about maybe a hobby or activity that I think is making the situation worse. It's not my place to tell you to stop that, but I also want you to be informed about, how to kind of tailor your goals and tailor activities to manage the condition that you have. Overall, how is this impacting your well-being? We want to treat the patient as a whole. My goal is not just to fix a picture. I don't want to see an abnormality on an x-ray and be too focused on that and kind of miss the bigger picture. We want to, again, get that bigger picture. So that's where it's really important also to match the symptoms, the history, everything we were just talking about as far as what you bring to the visit with what's going on the test results. I think a lot of times there's a thought that, oh, well, we need an MRI to see this to get the diagnosis. Actually, in neurosurgery, usually we're making what's called a clinical diagnosis. We're putting the whole picture together. It's the symptoms, the neurologic exam. That's why it's really important to see you in person, to actually examine you, check things, to help put those together with the imaging, and then kind of have an overall picture of what's going on to get the right diagnosis. We also want to know, in thinking about something as major as surgery, what have you tried so far? And it's not true for every condition, but for a lot of conditions, we really do want to try non-surgical treatments first, mainly because they tend to work and also because they're lower risk than surgery. And sometimes surgery may be quite low risk in the initial setting. So actually undergoing anesthesia, undergoing surgery, recovering from that, you might be very healthy and able to tolerate that just fine. But especially with a biomechanical structure like the spine that's moving, that's supporting you, that you have to use for the rest of your life, if we start tinkering with that structure with surgery, that can have actually really longer term consequences. And sometimes surgery just leads to more surgery, leads to more surgery. So if you've kind of tried everything else already, and it's been really kind of very thoughtfully done, and you've worked through everything, you've nonetheless been dealing with this, and it's really impacting you, very reasonable to think about surgery. Very reasonable to say, yes, I get that there are some longer term consequences, but I do need to address quality of life today. So understanding the goals, your quality of life, and kind of what's been attempted so far is very important in the whole picture. Only if you know and we know your goals of treatment are you able to judge if the treatment was effective. And to me, that's really the essence of quality in healthcare. A lot of times we talk about quality as not having had complications. That doesn't really help you, though. If I do a surgery and you don't get an infection and you don't get a blood clot and you don't go back to the hospital, well, that doesn't mean that the surgery actually fixed what we were trying to fix. And the last thing I want to do is an unnecessary surgery and expose you to risk when it was not effective or when we could have avoided it. So in thinking about, well, did this actually accomplish the goals of what I set out to do? We need to know those goals up front. We need to kind of have that conversation and then refer back to it and say, well, did we actually accomplish what we were setting out to do? That's where the decision-making really becomes personalized. My goal as a physician, as a surgeon, is to treat you right in front of me, not to treat a generic patient, not to treat a textbook. You have to be, again, at the center of that decision-making. In thinking about this, sometimes what I see in other surgeons' documentation and notes is really kind of the sense of the goal of being to do surgery, that there exists a procedure that we can do, therefore we should do it. That's not my goal, and I would encourage you not to make that your goal either, really, just to do the surgery, do the procedure because it exists. There's a lot of different surgeries that exist out there. It doesn't mean that that's actually going to be effective for you or get you better. So again, taking a step back to say, well, our goal is actually to get you better. If surgery is the best tool to do that, then that's great. By all means, we should pursue it. But that's what we have to sort out first. So an example there is just the general category of degenerative spinal disease. This can take many different forms. Another way to refer to this would be spinal arthritis, wear and tear of the spinal joints. Another example of this would be disc herniations or disc disease. Very important to remember in kind of that wear and tear degenerative process that no two people are identical. That refers to not only the individual and their interests and their well-being and what symptoms they're having, but also just the exact composition of their spine, how severe that disease might be, what the progression is, what the rate of symptoms is. That varies tremendously from person to person. So, we, in areas that we're unfamiliar with, our tendency is to anchor to what we know, to think about the experiences of people we know. And so a lot of patients come to me and talk about what happened to their parent or their sibling or their friend that had this same condition, quote unquote. Maybe it's the same title like spinal stenosis or degenerative disease. To be honest with you, that experience is largely irrelevant to your experience. Again, because you are a different individual. I wouldn't be able to speak to what their imaging looked like, what the thought process was for surgery, why they had maybe a complication that they had, or maybe why they did well without surgery. So we want to be careful to, have that experience, have that information. Maybe it informs the questions that you ask, but I would recommend keeping an open mind about what's best for your specific situation. And I think a big part of my role is to try to help educate and put that information together and put it into plain language to say, well, this is what I think is going on based on what you're telling me. And so this is what's right for you as the individual based on what we know. Our typical approach is to start with a lower risk treatment and then escalate treatment as we need to. You can think of this, especially for acute pain, as kind of a kitchen sink approach. We're throwing a bunch of things at it and we're trying to see, what sticks and what works. Partly because we don't always know ahead of time. There's no treatment that's 100% effective. As I said at the outset, there's no guarantees. But if we start with something that's low risk, then we're really not losing much by trying it. And also bearing in mind, and what I'll share with patients is we might propose something as the first treatment, but it doesn't mean it's the only treatment. So not to get discouraged if we try that and you're not seeing the results that you want, then we can go on to the next thing and we can escalate accordingly. It's always about at each level balance that risk and benefit trade-off. In the case of spine conditions, usually that involves things like physical therapy, massage, chiropractic. I put in a note here that I don't recommend quick chiropractic manipulation for the neck. There's a risk of stroke associated with that. But chiropractic for the thoracic and the lumbar spine, kind of the body, the abdomen, that's quite safe to do. Shouldn't have any issues there. Acupuncture using an inversion table, injections, various medications that you can talk to your doctor about. These are all things that we can use quite effectively in the setting of acute pain to sort of help manage the intensity of the symptoms. It's not that we're fixing the problem per se, but remember that the body itself has a tremendous ability to heal. So it's not that you're a machine and that we always have to go in and fix something. Your body brings with it its own healing capacity. So sometimes what we're doing with these treatments is just lessening the symptoms, making the experience more tolerable while we're waiting for some of those natural healing mechanisms to take hold and to work. And the good news is a lot of the times they do. Sometimes we have to go in and fix the problem with surgery. And we have to take an invasive approach and we have to take some upfront risk. It's thankfully rare in spine conditions, especially folks that I'm seeing in the clinic, where we'll recommend surgery upfront. But there are exceptions to that, and just recently I saw a young patient who has compression of his spinal cord and is getting symptoms from that, is having a harder time walking, harder time using his hands because of that spinal cord compression. And so I was explaining with him that the safest thing to do actually is to do surgery because there is a risk of waiting. There's a risk of trying to manage it without surgery, that the symptoms can just get worse and that he could be left with more permanent symptoms as a result. So there are exceptions to this rule. I think rather than thinking of surgery as aggressive or not aggressive as the treatment, it's more about, is surgery the right treatment for your diagnosis? Not about whether it's kind of aggressive, invasive, et cetera. It's about pairing it correctly with the diagnosis and making the right diagnosis. That also has to do with something called the natural history of a disease or of a particular diagnosis. And what the natural history means is, what does the body do? What is it about the body's own healing capacity? Where is that problem going to kind of fix itself? Does it improve with time? Natural history means, if we just let nature figure it out, what happens? And our usual rule here is that we don't want to intervene on that. We don't want to go into the body and change something. If you're not having symptoms from it, there's of course exceptions for cancer, for example. You might have a tumor that's found that's not producing symptoms that we want to take out in a lot of cases. But sometimes you might have a benign tumor that's very small and that's not causing any symptoms, and we can monitor it. So it also depends, even in the case of something like a tumor, knowing kind of what it is, making the best diagnosis we can about what it is ahead of time. In cases of spinal disease, just run-of-the-mill things like disc herniations or degenerative disease, a lot of times pain, especially in a new episode of pain, is going to get better with time. So we don't want to expose you to the risk of surgery if we don't have to. On the other hand, if it's a situation like spinal cord compression, as I mentioned, if there's neurologic symptoms, if you're losing function, then we do want to operate more urgently rather than kind of waiting and seeing or trying things like physical therapy. Physical therapy is not going to fix a spinal cord problem. The spinal cord itself is damaged. We need to go in and fix that. So it's also sort of, again, about understanding the diagnosis and where do we expect it to go if we were not to do surgery. When we think about surgery, you may have, encountered this already if you've had procedures done, that you sign a form indicating informed consent to surgery. But I think that framework can be useful not only in thinking about surgery, but in thinking about a lot of important medical treatment decisions. So there's kind of four big aspects to informed consent that we talk about. And your surgeon should be talking to you about these aspects. If they're not, then you should ask. And if they refuse to talk about these aspects, you should not proceed with that surgery. One is the indications. This kind of speaks to the diagnosis and the logic behind the surgery. I think my job is I should be able to explain to anybody the logic of why I'm proposing the surgery that I'm proposing. If we don't do surgery for the right reasons, we're not going to get a good result. So this is kind of step one. Step two is, what do we hope to come out of the surgery? What benefit, what good is going to come to you as a result of doing surgery? And it might be, in some conditions, just simply preventing the problem from getting worse. Sometimes that is the best that we can do. We may not be able to fix the underlying damage that's already been done. But thankfully, in a lot of times, one of our goals is to actually get you better, to get pain better, to get function better. And so we want to have a clear understanding, again, going back to what I mentioned earlier about, we want to have a really good understanding of why are we going into this? What do we hope to achieve? What are the potential downsides? What's the harms? And as I mentioned in spine surgery, sometimes that's the short-term risk, but it's also the longer-term risk. So thinking about both of those factors and taking a longer horizon to say it's not just about the medical risks of anesthesia. It's not just about the medical risks of being in the hospital, which for some people, those can be significant. And for some people, they can be so significant that we don't think surgery is a good idea. So even if we check all these other boxes and we say, yeah, surgery would be the ideal approach, but guess what? The risk of a serious medical complication, the risk of death is so high that we don't think it's a good idea to proceed. So we do have to think about the harms and be honest about that. And then bearing all that in mind, what else can we do? What is a reasonable treatment alternative to surgery or to any particular treatment? And notice I said reasonable, and that's because, as I already said, there are procedures we can do. We can physically go in and tinker with things, but that might not have any bearing on what your diagnosis is. The diagnosis that you have may just not be a structural or surgical condition. So I see this quite often from physicians and from patients that, well, I have back pain and it's not getting better and I've tried all these other things. So what I'm left with is surgery. That's not necessarily true. It has to go back to, do you have a surgical diagnosis that we can actually treat the surgery? And what surgery would we do to do that? So it goes back to having a reasonable expectation of success. I want to touch briefly on seeking second opinions and also some red flags to kind of watch out for from specialists, and I think it's important that patients can hold physicians accountable too, that, we owe you a certain duty of trust. And if that's not happening properly, then these are some of the things to kind of watch for. Seeking a second opinion is perfectly valid, especially for something as major as surgery. And as I mentioned at the outset, I would never be offended if you were to ask for seeking a second opinion. And in fact, I could recommend folks for that particular condition who you might want to see. That, I think, is a big red flag if someone is pushing back on that. So if it's something that's very low risk, if it's something like getting X-rays or MRI done, it's probably safe to go along with it, even if you could debate, is that actually necessary or not? But if you're getting pushback about getting a second opinion for surgery, that actually should prove to you that that's all the more reason you need a second opinion. That generally most respectable surgeons, most folks worth their salt will be amenable to that, would be happy to talk with other surgeons about your care, because at the end of the day, we should care about making the right call for you. Other red flags you should, be on the lookout for that I've unfortunately heard from patients, that have gone to other folks for consultation, scare tactics that are used that, if you don't do surgery, you'll be paralyzed. That's almost never true. I mean, there are cases where we worry about the risk of progression of symptoms. But my goal actually is to inspire confidence in you and inspire knowledge and not to scare you into something. Again, we want to both go into it with the right information. And the same goes with making false promises of guaranteed success. I had a patient not too long ago for whom I had a very honest conversation about their surgery and said, these are the reasons why I recommend it in light of these risks, these negative things that can occur. They didn't like to hear that there were risks associated with the surgery, sought a second opinion. That surgeon told them, well, this is a risk-free surgery. There's no risk. This is very straightforward. And then unfortunately, she had a major complication. So, that doesn't help anybody to go into it with mistaken expectations or, false promises that it's guaranteed to work and you'll do just fine. Folks who are exerting some type of time pressure to quote unquote sign up for surgery, you're not signing up for a cruise, right? I mean, this is not like something that, you have to jump on board with or you're losing your spot in line. That's just not how it works. If it's an urgent surgery, we're going to reschedule other patients or we're going to move our schedules around to get it done. And if it's not an urgent surgery, then that's okay. Then it can be scheduled electively and in a safe way. So, be on the lookout for that. You shouldn't feel like unnecessary time pressure. If there is urgency, it should be based on clinical reasoning, and you should ask about why it's urgent or ask about what's the risk of delay. Or if a surgeon's unwilling to answer important questions that you have, or they're just not providing a lot of information, if they get annoyed when you're asking, important questions, that's again a red flag that why are they not being transparent, right? Again, they should be able to explain to anybody those elements of informed consent that I just said. That's just kind of part of our training and a standard part of the job. Keep in mind that as much as we would like to take away all risk completely and to give guarantees and to make you feel 100% at peace, there just are no guarantees in any aspect of medicine. All I can promise you, all any surgeon can promise you, is our best effort, our best intent to getting you better, and our best knowledge, based on the training we have, but also constantly trying to learn and improve. One central aspect, I think, of being a surgeon is identifying risks that we can manage. Some risks we can't manage. Age, for example, I can't do anything about your age. It's only going to go up. But if there's other risk factors like smoking, for example, which we know is a risk factor for spine disease and we know complicates spine surgery, well, that is something we can do about. And that's the conversation we have and something we work towards to try to mitigate those risks, try to lower them to make it safer. We can offer some predictions about what's going to happen. We can speak to past experience and kind of speak in general terms, but the reality is the brain and spine are very complex, very mysterious. It's one of the reasons that I got interested in this field is because we're always learning more about it. We're always advancing the field. It's definitely an exciting time to be in this field, but with that complexity and mystery comes difficulty in making exact predictions about will you actually get better from the surgery or when will that happen or how much improvement can occur. And you deserve an honest answer about the limits of what we know and what we can predict. Surgery ultimately is not just about what the textbooks say. And again, that goes back to why personalization is so important. There is an element of art here of meeting the patient where they're at and kind of bringing that knowledge base in, but coupling it to what it is that we're trying to work on as an individual. And only if we operate for the right reasons, make the right diagnosis, have the right rationale going in, are we going to get the best outcomes. This is actually one reason it's very hard to study surgery because there is a lot of individual surgeon decision making that goes into why surgery is recommended, why a particular surgery is recommended, how well it was done technically. It's not like studying a medication where a drug is produced and put in a pill and everybody gets the same pill and it's standardized and that's kind of by design. Surgery doesn't work that way. So it's actually one of the reasons it's so hard to predict how someone is going to do, because even if we try to look at large scale studies, there's so much variation in what's going on there. And how successful overall surgery is depends on how well it was tied to that underlying diagnosis. Ultimately, wrapping kind of all of this up, surgery is about trust. You have to trust that I have your best interest at heart, that if we're proposing surgery, we're proposing it for the right reasons. And also that when you're in the operating room, that I know what I'm doing, right? Fundamentally, that's a huge leap of faith, a huge aspect of trust. And that's something that I don't take lightly at all. Likewise, I have to trust that you're committed to the whole process, that you know what you're getting into, and that you want to continue with that recovery even after surgery. And a lot of the neurologic conditions that we treat, as I explained to a lot of patients, surgery is step one in the treatment. It's a huge step and it's a big step to recover from, but it's still just step one. Step two is often time, letting the nerves heal, letting the spinal cord heal, letting the brain heal. And a third aspect is the rehab, is the physical therapy, occupational therapy, working on getting stronger, sometimes relearning, how to walk, how to move. That is a very much dependent on effort of the patient. And, that in my mind is always harder than than me performing the surgery. Usually most of our surgeries just take a few hours, but to recover from something like that, again, is a big commitment. Without that kind of full commitment, that full planning going in, we're not going to get the best outcome from the surgery. And in fact, sometimes depending on what happens, the surgery might turn to be more harmful than helpful. So we have to trust each other in that process and be open and honest with each other. So that's all I have. I'm happy to stay as long as needed to answer questions and look forward to more discussion.
Okay, thanks, Dr. Nathan. So it looks like we have a question or two in our Q&A, and then I also have a couple that were emailed ahead of time, so we can kick off with that. If you have a question you would like to ask Dr. Nathan, you can pop it into the Q&A feature, which is at the bottom of your Zoom screen, and you can ask questions anonymously if that's your preference. Just make sure you select that before submitting. All right, so let's jump right in. Might surgery be needed if you have a lesion on T2 and it is causing symptoms and pain? Are there other options?
Yeah, that's a great question. It's hard for me to, answer specifically without knowing what kind of lesion it is. And also, goes back to connecting the dots, so sometimes when we get imaging studies done, we'll see abnormalities, but trying to actually correlate that with the pain symptoms, with other symptoms, doing a neurologic exam. At that level in the thoracic spine, just speaking generally, we do think about what's happening with the spinal cord, what's happening with some of the nerves that are nearby. So it's very hard to answer kind of in general terms. Sometimes too with lesions that are unclear diagnosis. A lot of times what we can do is what we call active surveillance or serial imaging, where we follow it over time to determine if there's a change. And depending on, what the symptoms are now, that also informs how quickly we need to follow it. So that would be kind of the best that I answer. Sometimes that, we treat that with surgery up front if we're worried about something like a cancer or aggressive lesion. Other times we can observe it.
Okay, we have a question from someone who has a diagnosis of lumbar stenosis with leg weakness in both legs. They've seen physical therapy. It looks like a physiatrist, two surgeons, and a neurologist. So their recommendations seem to be conflicting to this person. What can a patient do if they're getting conflicting recommendations from different providers?
Yeah, that's a great question. And that unfortunately does happen sometimes. I think folks have good intentions and are going to look at it from different perspectives. As far as, something like weakness is concerned, you definitely want to make sure that a good neurologic exam is done to help understand if it's weakness when the physician is testing the legs and actually kind of checking strength versus if it's more of a weakness because of limited walking distance, let's say, or because of early fatigue of the legs. So kind of fatigue and weakness are two different things. So, really kind of spending a lot of time thinking about the exact symptoms, the examination. Sometimes when there is conflicting information, going back to the physicians and pressing them a little bit more on, well, what do you think the diagnosis is? Stenosis by itself, for example, is not a diagnosis. It's just a description of the imaging. So the diagnosis has more to do with describing the symptoms and putting that together with the imaging. If there's agreement on the diagnosis, that helps to kind of know if everyone's on the same page there. If there's disagreement there, then you do have to kind of untangle why it is that way. And then it's also sometimes a situation of someone might recommend surgery, but it's also a question of timing. So, maybe surgery could be in the cards or is in the cards at some point, but there's some other steps that need to occur before that. So if that's the issue, if there's a conflict about timing of the intervention, trying to clarify that versus is someone saying you need surgery and here's the reasons why, and someone else is very definitively saying no, you don't need surgery and here's the reasons why. So kind of understanding exactly where that disagreement comes from.
Okay. So there's a question about it's sort of like the chicken and the egg. What comes first? How do you get to your imaging before the neurosurgery appointment? Is there a provider you should see that would recommend imaging? How does that work?
This is a great question. There isn't one answer for everybody. It comes down to the particular provider, their level of comfort managing that diagnosis, their experience with it, their experience with ordering imaging. Sometimes primary care doctors are worried about ordering the wrong imaging study and don't want to do that. And sometimes I'll be honest with you, there are insurance barriers that can get in the way of getting certain imaging tests done. And not all specialists, not all physicians feel that they can navigate that process. It's just a reality of modern medicine that can be a barrier too. I see a mix of patients. I have some patients that are referred without any imaging studies done. Usually that's a little bit confusing, to be honest, because the question is, well, how do you know that they have a surgical problem? Why are you sending them to see a surgeon if there hasn't been any imaging done? So my advice would be if you're seeing somebody and they're recommending seeing a surgeon, but they haven't actually told you if there's a surgical problem or done any testing to work it up, I think it's reasonable to ask them that and say, well, how do we know that this is a surgical issue? If they don't feel comfortable with that, then usually a good intermediate step is either seeing a neurologist, because neurologists constantly manage conditions that don't necessarily show up on imaging studies. So they can sometimes be helpful in guiding that diagnosis. Again, depends on the symptoms. If it's more of an issue of pain, then seeing either physical medicine and rehab or pain management can be a helpful next step rather than necessarily going to see a surgeon. That being said, our clinic is set up where if you're seeing a primary doctor and they refer you to see us, even if you haven't had imaging tests done, we're happy to kind of start that evaluation and decide, A, does imaging need to be done? Because it doesn't always. And B, if it does need to be done, what type of imaging do we use? And that kind of goes back to what diagnosis do we think that it is.
In the case of a patient who hasn't had imaging yet, but suspects that they will probably need to have imaging, is there a possibility to do a virtual appointment for something like that? Is that something you can recommend in that way?
Yeah, that's a great question. So we do have the ability to do telemedicine appointments, a virtual visit if that's desired. Some of that boils down to patient preference and geography. We also have something called an e-consult, which is where your primary doctor can ask us a question without you necessarily have to come in. So they might just, send us your information and say, hey, this is what's going on. This is what I suspect might be the issue. Keep in mind that both of those are, still sometimes associated with a charge, with that, just like it would be if you came in for a visit. But those are some options that are available if transportation's a challenge, or if there's other reasons to kind of not necessarily have to come in person.
Okay. So there is a person here who had back surgery 2 weeks ago and then had a complication post-surgery and was in the ER, stayed 2 days. Their doctor never reached out to them. following the ER stay, and I believe did not call them back after they called. Um, is that a normal thing for the physician to do, or what is that relationship after the surgery is complete? What can you expect from your surgeon?
Yeah, well, first of all, I'm sorry to hear that, there was a complication and that you had to go to the ER. Obviously, no one, wants that to happen. I really can't speak specifically to that case because um, the reality sometimes too is that we can be quite siloed in communication. So depending on, where the surgery was done, um, where the surgeon works, it's not always the same thing. The surgeon might do surgery at a particular site, but that might not be their only practice location. And then keeping that in mind, then knowing how the ER might or might not communicate with that surgeon. There's so many steps to that communication process that unfortunately there can also be breakdowns in that communication. I could only speak to sort of my practice, which, I think thankfully with IHA and Trinity kind of being under the same roof, our clinic is on the hospital campus. We do surgery either here at the hospital or at the Schoolcraft Outpatient Surgery Center. So our systems all talk to each other. We're on the same record. We kind of get to know each other as far as who's in the ER, who's in these facilities. And so I think the communication tends to work really well. I think we work well as a team where even if, let's say, you had surgery with me and you came in the middle of the night, I might not be on call, I might not be available, but there is a neurosurgeon on call if there's something that's truly an emergency. Otherwise, I'm going to find out about that during daytime hours and then would certainly want to follow up. I think my goal, especially in the early period after surgery, the first couple of months, is to sometimes, be vigilant, right? And to watch out for complications and then think about, okay, if we sense that a complication is developing, how can we maybe nip it in the bud? How can we manage it when it occurs? So I would just encourage, again, not knowing all of the details, I don't want to tell you how to feel about it, but perhaps a little bit of benefit of the doubt, try to reach out again. If you're still not getting what you need, kind of find out how to escalate that to whoever sort of oversees that surgeon in that practice, because I think a patient who has agreed to have surgery, again, that trust goes both ways. And so it's our professional duty and what we owe you afterwards is to follow you and kind of shepherd you through that recovery process.
And is it fair prior to surgery to ask your surgeon, just planning ahead, if I have a complication, what's my best course of action? Is there a person I should call? Is there a number I should call? Do you prefer an electronic outreach?
That's a great question. And that goes back to being proactive and kind of thinking about risk mitigation. But usually that happens from the surgeon's office. And in fact, there's a lot of kind of rules on that for surgeons and for facilities that once you're discharged from a facility, and that includes even outpatient surgery. When you are leaving an OR, leaving a hospital, we have to give you instructions on what to do in the event of an emergency. So it's our job to tell you, here are the things to watch out for. If this happens and it's not an emergency and it's not a life-threatening condition, then this is the number to call. Our practice has that number staffed 24/7 so that if emergencies happen off hours, we have someone to respond to that. And also, a good rule of thumb is that if you can always ask the surgeon where they practice to kind of find out, are they only at one hospital or others? But a good rule of thumb is to try to follow up at the same place. If you're able to go to this ER of that same hospital, if it's safe to do that, that's better than going to a different ER because we'll know you. We'll immediately have access to your records. They can probably contact the surgeon who did the procedure. There are cases where transfers can happen, but it's good to kind of know that contingency plan. And again, usually we're going to provide that guidance as a matter of routine.
Okay. I know I've experienced cases personally, but also there are a couple people, and one actually emailed a question in that sometimes you schedule an appointment with a surgeon because they were referred by a friend or an internal medicine physician. but then that surgeon doesn't actually specialize in your specific diagnosis or issue, and you get referred to another surgeon. Is that, does it make sense to ask specifically for that person in spite of that? Or is it best to kind of rely on that office staff to really find you the best person for your condition?
Yeah, that's a very good question. It ultimately, I think it's personal preference. There isn't a 100% right or wrong way to do it. The reason I say that is, let's take an example of brain aneurysms. I don't treat brain aneurysms surgically, and that's because that requires a whole other level of training. Different fellowship training is, considered one of the specialty areas in neurosurgery. Much like someone who treats brain aneurysms all the time might not be comfortable doing some of the spine procedures that I do on a routine basis. Um, but for something like a small aneurysm, that might not need surgery. So it's reasonable still to say, if someone had a good experience seeing me, or had a reason to come see me in particular, that might be still a visit that's worthwhile. And we can talk about kind of the rationale and what to watch for and when you might need to have surgery for that condition. So it's not 100% wrong. At the end of the day, within neurosurgery, we kind of had to learn everything within neurosurgery. So even if we don't do the actual surgery, you may not need the actual surgery. You might just need to have a neurosurgeon look at it and weigh in. That being said, it's also perfectly appropriate, when you're calling to make the appointment, to say, hey, I heard good things about Dr. Nathan, but, is there somebody in the practice who does this more regularly? And usually you want to be, especially if you're thinking about a procedure, you want to be doing that procedure with somebody who does that quite often, is within their level of experience. It's also perfectly valid to ask those questions, of the surgeon and find out, well, tell me about, about a little bit about your training, what procedures you normally do, how often you've done this particular surgery.
Okay. Um, so there's a question about quality of life. So their pain can be so subjective, right? And so what are your recommendations to know when your pain is in fact really impacting the quality of your life?
Yeah, that's an excellent question. And I think uh, even the way that we in medicine often try to take that history and get that information is, it can be really hard to capture, and I don't think we do a great job. So we use a 1 to 10 point scale, for example, and I think a lot of people think that that means compared to others, and they sort of try to judge what somebody else's pain might be and how they feel. And actually, it's just a scale for yourself. When you're being asked 1 to 10 on a pain scale, that's just based on your personal experience. Because at the end of the day, pain is subjective. There's a lot that gets wrapped up into it that actually produces the feeling of pain and the experience of pain. It's very different if you have acute pain versus chronic pain, for example. We know that there's changes in the brain that occur. So it's not really about trying to compare to somebody else. I also think people feel like if they don't answer a certain number, that it gets written off or that they won't get treatment. And that's not the idea either. It's really just to try to make this very subjective thing a little bit objective, put a number on it. But usually when I'm asking about pain, I don't actually even usually ask about the numbers. I more so ask about, well, tell me how this is impacting your day to day. What things are you avoiding or not doing? I think that focuses the conversation not just on the number or the experience of pain itself, but gets back to this person's question, which I think is a great one on quality of life and level of function. One way to track that as a person, for you, the individual, is a pain diary. And actually just, it doesn't have to be every day, but jotting down notes for yourself, whether that's on your phone or in a little journal of, what can you do, what can you not do, so that you actually then create a record for yourself over time of how it's impacting you. And you can even bring that to your appointment, to help talk about, you know, how you notice this decrease in quality of life. Um, what is acceptable for one person is not necessarily acceptable for the other. And so that gets back to this individualization of treatment. And our job is not to judge that, but our job rather is to say, what can we do to facilitate you getting back to that desired level of function.
So it doesn't necessarily mean it has to be debilitating. It could mean simply that you're not able to do something that you really enjoy doing.
Exactly, exactly. Yeah. I mean that again gets back to what's that acceptable threshold. And so one easy way to wrap that up that I'll sometimes ask folks is, is this bearable? Can you manage? If you had to live the rest of your life with this level of pain, could you? A lot of times people will say, yeah, it's not great. Like I wish it wasn't there, and I understand that. But they recognize that they're managing. They're still doing their job or doing what they need to do. Other times the answer is no. And so then we want to think, okay, well, that's clearly, it's not an acceptable quality of life. How do we improve quality of life?
Okay. So there are several people who are asking questions that are a little more specific to spine issues that they may be having, or people who've had a number of different surgeries. So if you have people who've had maybe a chronic condition, or they've gone through a number of surgeries and they sort of feel like they've hit a plateau in terms of treatment, are they able to see you for a consultation?
I mean, I'll certainly see patients who've had spine surgery before, including second opinions. So it kind of goes back to, is there another situation now that can be treated with surgery? And also, as I had mentioned in my talk, reflecting on the surgery or surgeries that were done before, why were they done? And did the patient improve? Was there a period of time where you saw some improvement and then got worse? Versus if a surgery was done and one never got improvement, well, that doesn't necessarily mean that more surgery is going to fix that problem. But the short answer to the question is yes, I'm happy to see patients who've had surgery before, and especially, if folks are thinking that another surgery might need to be done.
Okay. And let's see, can you talk about an MRI? Is it a safe test to have? And does it have any impact on the brain given all of the electrical impulses happening inside the brain?
So that's a really good question. The best of our knowledge so far, and we've had MRI technology in clinical use since the 1990s. So, it's still kind of relatively recent, but it's been around for over 30 years now. So the best that we know is kind of for individuals getting, multiple MRIs that we don't see long-term impact or changes to their brain function or to nerve function because of the MRI. Part of the reason for it has to do with the fact that it is a magnetic field, but it's a relatively short amount of time in kind of the overall span of life. Sometimes people do get side effects from that, or they can feel odd sensations when they're in an MRI machine. And that's not necessarily dangerous, but it does speak to this fact that you're in a strong magnetic field for a while, and that can alter some of the nerve signaling. But to my knowledge, there isn't any evidence of long-term harm. There are MRIs that can be done without contrast, which is it's a chemical agent that is injected, into the vein that helps light up things like blood vessels or infection or tumor on an MRI. If it's done without that contrast, then to my knowledge, there's almost no risk associated with getting an MRI done. We want to be careful about implanted devices. So people who have pacemakers for sure, or have had other surgery, the radiology team does a great job of kind of screening all of that. Folks who are getting contrast, there is a low risk of some, quite rare complications associated with contrast. So that's why we don't order that with contrast as a matter of routine. Usually they'll want to do some lab tests first, check your kidney function, et cetera, to make sure that you can get contrast. But one important thing to know about MRI is that there is no ionizing radiation from MRI, meaning there's no radiation dose that your body is receiving the way that it does with X-ray or CT. So there's no associated risk of cancer and having to worry about radiation causing cancer when it comes to getting an MRI done. MRIs, by and large, the way that they work is they work on water molecules in your body, and just temporarily kind of adjust the way the atoms in the water molecules are. just for, really a fraction of a second, and then they stop, and it happens again, and they stop, and that's why they make that banging sound. It's kind of exciting and relaxing, exciting and relaxing. And through very complicated math and computer systems, basically take that and create an image. So it's an amazing technology. It's really useful for seeing the brain, the spinal cord, the nerves, for seeing soft tissue. It's just completely revolutionized neurosurgery because we essentially never have to do exploratory surgery anymore. We can see in excellent detail where the problems are. We can build a mental image of that going into surgery. And then in surgery, we see what we were expecting to see. It's almost unheard of nowadays that you go in and sort of see something totally different. So I think overall it's very positive, very safe to use.
And is there an alternative test that can be done in lieu of an MRI? I know a lot of people do have anxiety going into like the tunnel, so to speak.
Yeah, one of the downsides with MRI is it can cause more claustrophobia. It's a tighter space. Um, that I think it's really a specific question that you want to ask whoever's ordering that MRI, because it's very specific about what we're looking for exactly. I think even a lot of physicians have this mistaken impression that imaging is in different tiers, like you start with X-ray and then you go to CT and then you go to MRI. Nothing could be further from the truth. They show you different pieces of information. They work in so different ways that you can't necessarily swap one out for the other. So it kind of gets back to that question of like pinning someone down to ask them, okay, well, why do I need this MRI? What are you thinking it's going to show? As opposed to, maybe I don't need the MRI at all, if there's a concern about that anxiety. And in some rare instances, we can use alternative tests. And again, I won't sort of go into detail about it because it is quite rare in modern practice. But if we're really interested in looking at the nerves and looking at discs and ligament and what we call soft tissue, not the bones, there's no better study than MRI. So usually we can get around some of the anxiety issues by giving some medication. Sometimes open MRI machines can be done. The only problem is the images are usually not as good. So my advice would be if you really need an MRI done, if you're worried about the claustrophobia, ask whoever's ordering it about some medication to help you go through that. That's very, very common.
Okay. This person is asking if it is a red flag when the practice states that due to the number and of people and time involved with surgery scheduling, if you change your mind, you may not be able to schedule this with this surgeon again. So I guess if you cancel your surgery, the surgeon
Yeah,
probably won't be willing to see you again or won't be willing to schedule you again. Sounds like
I've
you're
never heard of such a
me.
policy, so
Okay.
I will just leave it at that. Yeah.
Yeah, that sounds interesting. I would say a second opinion, maybe.
Yeah, exactly. I can tell you that's not how we run our shop.
Right. Um, I'm just looking for a couple more questions. Oh, someone's asking about, so they are asking about the Da Vinci robot, but I would imagine that there may be other robots as well. Is the robot era kind of entering the neurosurgery world?
Yeah, thanks for this question. It's a really good topic. So yeah, the Da Vinci robot exists. It's been in practice for a while. We don't use it in neurosurgery. Part of the logic behind that is the way the Da Vinci robot works. It's really good for what's called laparoscopic or minimally invasive surgery, where what is happening is that the surgeon is operating on an open space in the body. So the abdomen has a lot of kind of open space. There's techniques to kind of expand that space during surgery so that you can insert a camera and then look around and then through small incisions insert instruments that can move in very complex ways. So it's a really an amazing technology. I've seen it in medical school, seen it in some of the surgeries that are done. In neurosurgery, we're not operating on open spaces. So if you think about your head, there really isn't any open space there. It's skull and then brain pretty quickly. In the spine, it's the same way, where there's really not kind of an open space or a space that we can create. There's an emerging field called endoscopic spine surgery, which is still in its early days. Most procedures that are done endoscopically end up taking a lot longer. than kind of traditional surgery, but we got to start somewhere, and people are interested in innovating and trying to see if that has some advantages compared to some of the current techniques that we have. Endoscopic spine surgery is one way to kind of incorporate really minimally invasive techniques. We have minimally invasive spine surgery, but this is kind of taking it a step further. Robotics in spine surgery exists, but also very early days and isn't a true kind of robot in the sense that you might think of it. We do already have, and I use this, a lot of spine surgeons use this. We have a navigational system that we use when we do spine surgery. You can think of essentially as a GPS for doing spine surgery. It's amazing technology. It really increases the level of safety with spine surgery. Right now, robotics and spine surgery, it's not the Da Vinci system. There's other companies, other platforms that make it. But essentially, it's a robotic arm that you can tell what trajectory you want it to take, and it will kind of move. And it's a guide for your instrument. So you can kind of put your instruments up and down, but it doesn't actually do any of the work or have an instrument attached to it. It's still the human surgeon interacting with it. I can tell you that there's people looking at ways to, kind of like a CNC machine, get a really precise drill that can be used robotically. That research is already underway. So there's some really cutting edge, ways to push that envelope, but not current state.
Okay. Somebody brought up a great question about a nurse navigator. So I know some of our programs do have a nurse navigator that is sort of your first stop, right? When you're entering any kind of like neuroscience division or physician, if you're looking for an appointment. Is that available in Livonia? I'm not sure off the top of my head.
So yeah, we do have a nurse navigator in Livonia. Her name is Maria Fox. She's been really helpful with trying to standardize some of the referral patterns or kind of patients who have particular questions want to be seen and kind of giving guidance on which way to go. So if you go to our IHA Cares website, and the Trinity Livonia websites, they'll have some information about that for spine. But I will tell you that we have a pretty open door policy in our clinic where we're happy to see folks. We're happy to, if there's a question about referrals, we're happy to look at that and provide even some initial guidance about referrals. So certainly utilize the nurse navigator, but don't hesitate to either have your doctor reach out to us or to call our clinic to see about getting a referral. Sometimes the issue of whether a referral is needed again kind of goes back to insurance. But patients who don't have kind of that insurance barrier, feel free to call and then we can kind of get that intake process started.
Excellent. And the nurse navigator can, if you're sort of checking off different solutions before you get to surgery, they can really help you with like, okay, you've tried this, now here's the next step, right?
They can provide some kind of general guidance. I think it's sort of a question of, are you starting at square one or is it a more
Okay.
complex situation? So there's some limitations to, how much advice they can give. But I also have a nurse practitioner, Brienne Barrett, who works with me, basically all the time here in Livonia in our clinic. And she will also help see patients independently, particularly patients who are earlier on in that workup process. Maybe their primary doctor needed some kind of guidance or recommendations on what imaging tests to order or thinking about things like physical therapy. So she's another resource that's available if for scheduling reasons it's hard to get in with me, then she's a great resource to help too.